अपना एक राज बताना चाहती हूँ। मेरा राज है to remain student throughout your life.
Yes.
And not only that, जो भी लर्न करो उसको शेयर कर लो। ये वाली बात मेरे को मेरे फादर ने सिखाई कि जो भी तुम नई चीज सीखोगे उसको आपने 4 लोगों को सिखाना।
बिल्कुल।
तो आज की तारीख में 4 लोग तो नहीं मिलते मुझको सिखाने वाले, क्योंकि सीखने वाले बहुत कम लोग हैं।
नहीं मैडम, सब आपसे तो सीखते हैं साहब। नहीं,
तो एक बात है, जो भी लर्न करो उसको सिखाना जरूर है। ये मेरा राज है यंग रहने का मेंटली। एंड आई फील कुछ भी नॉलेज लोगे तो आपको वाइज मैन एक दिन तो बना ही देगी।
बिल्कुल।
एंड सेकेंडली, अगर आप शेयर करोगे, दिस इज द फर्स्ट स्टेप द ह्यूमैनिटी। ये भी एक सेवा है। आप 2 चीज इंफॉर्मेशन, 3 चीज इंफॉर्मेशन भी आप लेकर जाओगे तो मैं कहती हूँ कि नहीं, वी हैव डन अ ग्रेट जॉब। So this is what I feel, and I'm going to take you back to MBBS class, but in 2021. कि ये सब क्या है, छोटी छोटी बात बताऊंगी मैं, और ज्यादा बहुत लंबी चौड़ी बात नहीं बताऊंगी, क्योंकि मैंने टॉक और अपनी डिस्कशन जो है वो 40 मिनट में खत्म हो जानी चाहिए। और उसके बाद एक आई मेट फिजियोथेरेपिस्ट who is a very decorated physiotherapist, returned from Japan. So he has an Indian things to say and a Japanese thing to say. And he's going to talk to you people, whatever your age is, how to remain healthy for 100 years. So I'm sure that 20 minutes talk is a bonus going to be, this is what we are going to talk about. I go back to my postgraduate days at PGI Chandigarh. वहां पर एक डॉक्टर थे, डॉक्टर चुग, who was the chief of nephrology department. He used to ask everybody, आपको 2 डिजीजेस है, आपको एक चुननी है, बताइए कौन सी चुनोगे? डायबिटीज चुनोगे कि हाइपरटेंशन चुनोगे? So at that particular time we found 50% people were divided. कुछ लोग कहते थे हमें डायबिटीज चाहिए, कोई कहता हमें हाइपरटेंशन चाहिए। तो he used to say, डायबिटीज आपको गला गला के मारती है, but it's still better than the hypertension. Hypertension, if it is uncontrolled, is going to strike you, और जो भी इसके टारगेट ऑर्गन डैमेज करेगी, और आप पाओगे you are at the gate of heaven without you knowing anything, without your family members having any time to take care of you. So this is the difference between hypertension and diabetes. I'm talking of my younger days. And he gave us another habit. कोई मरीज आपके पास आए, जब उसका आप हीमोग्लोबिन, यूरिन एल्ब्यूमिन, शुगर करा रहे हो, उसका जरूर सीरम क्रिएटिनिन कराओ और उसका जरूर SGOT, SCPT कराओ। आपकी छोटी बड़ी कितनी भी प्रैक्टिस होगी, 2 dozen cases of early kidney disease, you will going to pick it up just by creatinine and just by SGOT, SCPT. So this is the second habit I got from there, and I will talk about. I was sent a PPT. I was part of that particular presentations from Foxy. So मेरी दोस्त who is going to run for vice president post, she said me a PPT, and she said only one message you have to take it, doctor, and this is what you have to highlight when you're coming as a special guest on this. And I found it was a very simple presentation, and this presentation is on the American College website. Madam has copy pasted on her this thing. So this is not anybody's property. It is not my property, and this is not a property from Dr. Wagh from Pune. So I'm just going to share you with you now.
Now this is
That's right.
Yes,
Okay.
we can see that.
Now, this is the physiology of our blood pressure. So the heart pumps and elastic arteries dance. And that's why you find everywhere the blood goes in every cell in the body. When should we take blood pressure? When the patient comes to you, it has to be taken twice on 2 occasions. The person should be calm. And in the last 15 minutes, the person should have not smoked when you take a blood pressure. The right cuff has to be there. And in fact, if the bigger cuff is not available in an obese patient, you can do it in the arm. And the accuracy is the same. You can do it in the forearm. You can do the testing. The accuracy is same as what you do measure in the arm. And this has been shared with me by my anesthetist. You can see here that the normal blood pressure is systolic should be less than 120 and the diastolic should be less than 80. This is the normal blood pressure. Pre-hypertension is when it is between 120 to 139 and your diastolic blood pressure is 80 to 89. Stage 1 high blood pressure is between 140 to 159 and the diastolic is between 90 to 99. And the stage 2 hypertension is 160 plus and the diastolic is 100 plus. And as far as non-pregnancy emergency things are concerned, which we call hypertensive crisis, it is 180 and diastolic is 110. And why it is crisis, that in case if it remains there for 3 hours, you can find that target organ damage starts taking place. It is slightly different during pregnancy, and this is what the difference you should need to appreciate at the end of my second talk. This slide also I'm going to dilate in my second presentation, so I'm going to omit here. White coat hypertension, all of you know about it, and you need to explain to your patients sometime if they have hypertension while in the clinic, they should not get worried about. There's another term which is called a malignant hypertension, where the systolic blood pressure is 200 by 140, and by this name it shows that it can do so much damage to the individual. And there's a resistant hypertension where super specialists have to chip in to correct and control hypertension for the patient. Largely is asymptomatic disease. The investigations which this August gathering must do in any case of hypertension. Urine routine should be done, and there is a basis when I am going to come back what are the causes of hypertension. Diabetes must be ruled out by HbA1c. Serum electrolytes must be done, and the fasting lipid profile and 12 lead ECG need to be done. The people who are fond of doing fasting blood sugar and PP blood sugars, they should use 75 gram glucose, and that's very important. So this is what the basic profile has to be done in each and every case, and short of that, you will not be able to find out what is the cause and what are the effects of hypertension already in that particular individual. As to the complications I was talking about, target organ damages, the CNS complications are transient ischemic attacks, cerebrovascular accidents, subarachnoid hemorrhage, hypertensive encephalopathy. As far as the ophthalmic complications are concerned, retinopathy. Serious complications are coronary artery disease, left ventricular failure, blood vessel. I will talk about aneurysm again when I'm talking in pregnancy. And one of the complications of aortic dissection also can take place as a result of high blood pressure. And in renal complication, it is the renal failure. As for the treatment modalities are concerned, obesity requires focus and attention. Dietary modification, the DASH diet is very popular by this name as far as the hypertension is concerned. Exercise has got its own rules. I'm going to just touch about it. Smoking, the person has to give up, And alcohol has also a lot of restrictions. I will again going to touch about it. Stress management requires urgent attention and good attention by the individual, and they should learn the art of meditation. And there are a few medications only which has been there, and some are new, which I think all of us must know about it. We talk about diuretics, we talk of beta blockers, we talk of ACE inhibitors, we talk of ARB, which we come into the same category. Then there's a calcium channel blockers, alpha and beta blockers, central sympathetolytics. And by the end of my presentations, I think you will be mastered in this particular area. Now, as for the salt is concerned, कहते salt hypertension patients के लिए जहर है. So it should not be more than 2.5 sodium, or if you take sodium chloride, it is 6 grams. वो कहते हैं a half teaspoonful, what we flat should be the total consumption of salt. What is the DASH diet? It's mainly of the fruits and the vegetables, low fat dairy products, and as far as the saturated fats and the total fats are concerned, it should be markedly low. As far as yoga is concerned, it is, I think, a couple of tips the gentleman is going to give. I'm going to just leave it at that particular thing. BMI has to be done, kept between 19 to 25, and for we Indians, the upper limit should be 23 BMI. As for the alcohol intake is concerned, for the gentleman it is 2 pegs, and for the ladies not more than 1. And I think as far as we Indians are concerned, we should try to see that alcohol is one thing which should not be, we should be discouraged when the boys are getting nurtured in the house. Smoking they have to give up. And we have to control all risk factors. Now this particular slide simplifies very well. If the person is old, more than 55 years, the first line of treatment is calcium channel blockers. C means calcium channel blockers or diuretic. If it is not getting control on one, then the combination of the two will be done. As far as the young people are concerned, the principle is they will have ACE inhibitors or ARB. ACE inhibitors or ARB. Majority of us cannot name even 1 or 2 products in this. Anyway, you will learn by the end of this few prescription. Now, in case if it is not controlled on one, then ACE inhibitors or ARB have to be combined with calcium channel blockers. And if still not getting control, you can add diuretic. So this is the story of A, C, and D. Younger patients have to be given ACE inhibitors and ARB. And in case if it is not getting control, before the maximum dose comes, you let the calcium channel blockers chip in. And it's still not getting control, you can add on to diuretic. As for the old patients are concerned, it is calcium channel blockers, then comes diuretics, and then finally, in case still not getting control, you can add ACE inhibitors in such patients. Now, coming to the names of ACE inhibitors, enalapril 2.5 milligram, ramipril 2.5 milligram, the dose is in this range. Then telmisartan 20 milligram, 40 milligram tablets are available. These are all ACE inhibitors. Calcium channel blockers, nifedipine, amlodipine, 5 milligram, 2.5 milligram, whatever it is the dose. And diuretics which we use is hydrochlorothiazide, 12.5 milligram tablet. There are many terms used in the books: hypertensive emergency, hypertensive urgency, malignant hypertension, resistant hypertensions. You find in non-pregnant patients and pregnant patients, the books will give you a lot of definitions, and then at the end you have to make up your mind what you learned from us. I think that's finishes my, that's right. You can see the slide?
Yes, ma'am.
Okay. Now, this is the presentation I was talking about. Antihypertensive use before pregnancy and during pregnancy. What are the recommendations of American College and which is now followed in majority of the world? This presentation comes from Professor Girija Wagh from Pune. Now, my initial presentation sets the stage that pregnancy-associated hypertension remains an important cause of maternal and fetal morbidity and mortality. Mother and the child are the two souls which the obstetricians are supposed to take care, and it is their first duty to see both the morbidity and mortality is curtailed to their best. More evidence has confirmed that the pregnancy-associated hypertension can cause early childhood cardiometabolic disorder. All of you know that a baby who has got fetal growth retardation gets all the lifestyle problems, that is hypertension, diabetes, stroke, heart attacks, come as a gift to the growth retarded child. The similar way, there's another statement which we are making. More evidence has confirmed that the pregnancy-associated hypertension can cause early childhood cardiometabolic disorder. So, a patient of chronic hypertension, prior to pregnancy, if the woman is controlled under appropriate management, will have successful outcome during pregnancy. However, pre-pregnancy hypertensive women with poor control of blood pressure in the first trimester, they are significantly increased risk of target organ damage in both mother and the fetus, and the result is low birth weight, preeclampsia, and other adverse outcomes, which I'm going to just throw light on it. So this is what the difference between the people who are controlled on drugs and the people who are not controlled on drugs, that is in the first trimester itself. So the things are written right clearly. So our responsibility as obstetrician is not only to take care of hypertension during pregnancy and in a breastfeeding woman, but at the same time, we have to be very, very careful when we see an infertility case and whenever a patient comes to us in a non-pregnant state and who is trying to plan a child ahead, to plan and see meticulously that the hypertension control is our responsibility in this particular patient. We are of 4 types of individuals. The first category of individuals are always contented. They have no complaint. Koi shikwa shikayat nahi hoti life mein. They're totally satisfied and are calm people. The second category of patients, unko koi bhi baat bataye, unko achhi nahi lagti. They want to cling to the past. They are fearful always to adopt a new thing. And they are unaware most of the time what is happening around them. And you see all around you, you find this category of patients are far many. There's a third category of patients. Okay, मैंने MBBS 40 साल पहले किया. I am ready to listen to what Dr. Jain says. They're open. Risk, and then they are ready to take a new path, inspired, and then they can take actions. And there is a fourth category of people who are hooked to WhatsApp, social media, इधर की उधर, उधर का इधर जो है, they are always confused. कि मॉर्निंग में मंजू बारी कुछ और बताती हैं, शाम को डॉक्टर भास्कर कुछ और बताती हैं, मीनाक्षी कुछ और बताती हैं. They are already thoroughly confused. They do not know what way they have to take. So let's start with a very basic today. We are fond of using placebos. We use left and right. कोई फायदा नहीं होगा तो कोई नुकसान तो नहीं होगा. So we take a drug which is called low dose aspirin. Low dose aspirin, a woman who has a normal blood pressure has no role. आपने देखेंगे कि आप किसी भी पेशेंट में किसी भी बीमारी में प्लेसिबो पकड़ाओगे 40% को फायदा होगा. ये रूल है. पर अगर नॉर्मल ब्लड प्रेशर को हम एस्पिरिन पकड़ाओगे तो देखोगे कोई फायदा नहीं होता. So this is one lesson we must take. हम infertility में left and right एस्पिरिन यूज करते हैं IVF के पेशेंट्स में. This is a message for all of those people. Aspirin as such does not have a role unless you have a specific indications. But the patient who have got high blood pressure stage 1, 140 to 159 and diastolic of 80 to 90. Here it has been seen placebo has definitely more effect. But if you give aspirin, it is seen that the low dose aspirin may help pregnant women in the first stage of high blood pressure, and they can avoid preeclampsia, a condition which puts baby in danger during pregnancy. We all know about it, and that is the rationale that when we are doing a screening in the end of first trimester with the NT-scan, in case if we find that this particular person is positive for early preeclampsia, then we start them 150 milligram of aspirin, and it is said that it is going to avert preeclampsia in that particular patient. So we all know this people that the preeclampsia is a triad, which is by high blood pressure, the edema, and the proteinuria. And in case if it is neglected, we'll end up with problems of eclampsia and its complications, and the baby definitely suffers in case we don't take care of the properly. So these are the terms, very simplified, done and put up in this particular presentation. Chronic hypertension. Chronic hypertension, which is predates the pregnancy, it definitely has adverse effect, and that is the focus of this particular talk of this PPT. Gestational hypertension, which presents in pregnancy, it can be early onset if it presents early onset preeclampsia if it presents earlier than 20 weeks, and late onset is when it occurs after 20 weeks of presentations. And we all know that the PET is associated with fetal growth retardation and problems. Now this slide is very, very important because today's India has changed. People are postponing their childbirth into 30s and 40s, as well as by the time they decide about the child, they have obesity in addition. Chronic hypertension affects 3% of the pregnant women when they embark on pregnancy. And what are the adverse outcomes? From these 3% people who have a chronic hypertension in early pregnancy, preeclampsia will develop in 15 to 40%. I again repeat, preeclampsia will develop in 15 to 40% of cases. The cesarean section will increase 3 times. Postpartum hemorrhage shows an increase of 2.2 times. Gestational diabetes almost doubles. Triple is the risk of perinatal mortality over general population. If you compare with the general population, the perinatal mortality is 3 times. Placental abruption doubles. And if baseline proteinuria has been there, you can take it from me, there is an increased risk of preterm delivery and small for gestational age infants. This slide is very important, and all of the time you have to keep this particular slide in mind. Now this slide very beautifully summarizes what are the causes of hypertension. The causes of hypertension are that the primary hypertension or essential hypertension is there in 95% of patients. As far as the secondary hypertension is concerned, renal causes make 4%. Parenchymal renal causes are little more than the renovascular. It is said that parenchymal renal causes are 2 to 3% and renovascular is 1 to 2%. Endocrine causes are only 0.5%. Primary aldosteronism, pheochromocytoma, Cushing syndrome, acromegaly, big names. They only contribute vascular causes, coarctation of aorta, non-specific aortoarteritis. They only make 0.5%. So the kidney causes are 4%. Endocrinal and vascular make only 0.5%. Drugs also make 0.5%, and miscellaneous are obstructive sleep apnea as one of the example is 0.5%. So this summarizes the secondary cause of hypertension. That is 5% are the secondary causes, and in 95%, chronic hypertension is an essential hypertension. So you've got to know as a clinician the duration of this hypertension, the baseline investigation, which I just now talked about, the systemic evaluation is necessary, what all has been there now in our basket, and what are the comorbidities other than hypertension in that particular given case. Many old people are here. We find at times difficult to name even a couple of things, like ACE inhibitors. Agents that block the production of angiotensin and angiotensin converting enzyme inhibitors are called ACE inhibitors. In this category, I gave you the names: anapril, lisinopril, ramipril. These are associated with increased risk of fetal anomalies. Remember, their use is associated with fetal renal failure, IUGR, oligohydramnias, also associated with pulmonary hypoplasia and fetal death. I repeat again, on one side, there's an increased risk of fetal anomalies. On the other side, fetal renal failure, IUGR, oligohydramnias, they have pulmonary hypoplasia and fetal death. And it is also seen that such fetal adverse effects appear to occur regardless of the gestational age at which these agents were administered. It's not that your first trimester mein aap use karoge tabhi ye problem hogi. Nahin. It is irrespective of the gestational age. It's regardless of the gestational age when it is used that they are associated with problems. Agents that block action of angiotensin are called angiotensin receptor blockers, and it is said that the data of ARB usage in pregnancy is limited. They should be avoided as their mechanism of action are similar to ACE inhibitors, and they appear to have similar fetal adverse effects. So both are in the same category. So once we know about the ACE inhibitors and ARBs, we know that before pregnancy, we embark on pregnancy, we have to change the medication. Care should be exercised when prescribing ACE inhibitors and ARBs for women of a childbearing age, as a significant proportion of pregnancies are unplanned. So the younger people who you think are going to plan their child, as a policy matter, you should not try to use these two drugs. It should be avoided in a woman with chronic hypertension who are planning to have a pregnancy unless there is a compelling long-term indication like history of a diabetic nephropathy. These patients have to be also told that in your case, the patient should be advised to inform her doctor as soon as she misses a period that I am on ACE inhibitor and my doctor has said it has to be changed to suitable alternative. Now question is, we have to change the medication, but now shift to what? Alpha or beta blockers are the options. We've been using for a long time alpha-methyl dopa. All of us miss this particular drug very dearly for reasons known in the country that these drugs production has been stopped, and we have no other alternative. This drug had been there for almost 100 years, and labetalol we have been using it for the last 50 years. Again, it has got is one of the very safe drugs. No teratogenic effect is seen so far in the studies. Now question comes, why not atenolol? A large retrospective study of atenolol use in pregnancy suggested that it may be associated with intrauterine growth retardation, especially when administered in early pregnancy and continued for a longer period during pregnancy. So they are associated with intrauterine growth retardation. It also, the evidence suggested that atenolol impairs feto-maternal circulation and increases the uterine artery resistance index and fetal aortic pulsatility index. These two things are impaired. The evidence also suggested that the beta blockers may have a long-term adverse effects or very low birth weight of the neonates, resulting in increased neonatal mortality. And these are the three reasons that atenolol is not used, and the drug of choice is in this particular group is labetalol. There are still few more facts which add fuel to the fire of confusion. And I want everybody's attention should be there on this particular slide. Women with chronic hypertension, either treated or untreated, are at increased risk of congenital malformation in the offspring, particularly cardiac malformations, compared with the normotensive woman. Chronic hypertension का patient, चाहे उसको दवाई मिल रही है या नहीं मिल रही है, as such they are prone to more malformations and especially cardiac malformations. Another confusion is, although it is possible that the hypertension increases the risk of congenital heart disease in the offspring, and that the antihypertensive drugs further increase this risk, it is also possible that the hypertension and congenital heart disease share similar risk factors. Chronic hypertension से भी आपकी congenital heart disease बढ़ेगा और आपका drugs use करेंगे तो और भी बढ़ेगा. So they have a common risk factors. So now we have 4 entities. So there is something like chronic hypertension, and in pregnancy there is a 15 to 40% chance that it will develop preeclampsia. Then in case if it is uncontrolled, there can be eclampsia and gestational hypertension, which is all of you know about it. So you can see how the spread is there. The first half, chronic hypertension only controls the field, and in the second half, right from gestational hypertension, PET, eclampsia and superimposed preeclampsia dominate the scene. So coming back to again very basic slide, you must know what is hypertension in pregnancy is 140/90. This is important, establishing a diagnosis to know these two figures and deciding the blood pressure at which the treatment was initiated, the target blood pressure which you should have, and avoiding drugs that may adversely affect the outcome. It's a very simple slide. They've described a pregnant patient with chronic hypertension into 2, the low risk. Low risk when patient with just borderline 140/90. Who are not on antihypertensive drugs. They have the first trimester anti-scan and screening for preeclamptic toxemia. They have an AMLI scan, and the repeat scan is suggested around 30 to 32 weeks. And thereafter, they should have monthly scan till term. Antihypertensive drugs are added in case if there is a severe hypertension develops, that is 160/110. And if preeclampsia develops, if hypertensive drugs are used, or if the baby develops fetal growth retardation, you have to see to it that all fetal monitoring testing come in place to see that the good outcome is there of that particular patient. As for the high-risk patients are concerned, right in the first trimester itself, you find that the patient has got high blood pressure, requires a hospitalization with the aim to decrease the blood pressure to 140 systolic and diastolic less than 90 millimeter of mercury. Again, as I said, that not only the first trimester scans, you require an AMLI scan. In this particular patient, you require earlier ultrasound, that is at 28 weeks, and thereafter, instead of monthly, it should be done every 3 weekly until delivery, and can be coupled with Doppler also in case if it can be done. Non-stress test and the biophysical profile and a Doppler at 20 weeks, and then weekly thereafter can be used. Hospitalization, if there is an exacerbation of the severe hypertension, and if there is a PET, or if there is an evidence of growth retardation, then you can find a whole lot of fetal well-being testing comes in ready, and we should try to see that we do not delay the pregnancy delivery to be later than 37 weeks. Now, question is, what antihypertensive medications and the protocols? So we are very clear, the normal is the BP which is less than 140, the mild to moderate is 140 to 159, mild is 140 to 150, and moderate is from 151 to 159. And the diastolic is 90 to 100 in mild, and in moderate it is 100 to 110. Severe hypertension, we all know, it is more than 160 by 110. Now, this is the slide which requires your attention, and this is what was surprise to me also when I had got this particular presentation. There is a term called hypertensive emergency in pregnancy. If your the blood pressure is more than 160 by 110, lasting 15 minutes or more, it's of acute onset. It sets a lot of problem, and that's why it is said hypertensive emergency. BP of 160 and 110 persisting for more than 15 minutes create hypertensive emergency. And what are the complications as a result of this? CNS complications, including eclampsia, acute respiratory failure, problem of HELP syndrome, uteroplacental complications, accidental hemorrhage and sudden IUD, serious complications, acute kidney injury, hematological complications, and complications related to liver, hepatic complications. Whole lot of complications are there as a result of BP of 160 by 110 more, persisting for more than 15 minutes. So, American College Committee opinion came on emergency therapy for this acute onset severe hypertension during pregnancy and a postpartum period. So what it says, कहाँ आपके कान खड़े होना चाहिए और एक्शन होना चाहिए whenever the BP is more than 160 diastolic and 110 diastolic, persisting for 15 minutes or longer is considered hypertensive emergency. We have to fix it by first intravenous route, labetalol or dialysate, or nifedipine or oral labetalol subsequently. At the same time, magnesium sulfate is used to prevent neonatal seizures in premature babies. As well as we have to arm ourselves for the treatment of eclampsia, the same treatment. Another thing which you have to remember is loss of, whenever the blood pressure goes over 160 by 110, there's a loss of cerebrovascular autoregulation. I'm going to make it very simple. Now what happens? Whenever there is a hypertension during pregnancy, during acute hypertension, similar to what occurs during severe eclampsia and eclampsia, there is a forced dilatation of a large cerebral arteries. This is the non-pregnant state. And this you can find during pregnancy. So you find there's a forced dilatation of large cerebral arteries occurs, decreasing the vascular resistance, and with the result, greater transmission of hydrostatic pressure takes place to the downstream arterioles and capillaries. And the result is hemorrhage, edema, hemorrhage, and rupture. Edema, hemorrhage, and rupture. And this is because of the acute hypertension, which brings about forced dilatation and which brings about larger transmission of hydrostatic pressure to downstream arterioles and capillaries. Everybody talks about in Doppler, middle cerebral artery, and this is the area which it feeds: basal ganglia, putamen, thalamus, adjacent deep white matter pons, and a deep cerebellum. we find in the parenchymal in cortex, these kind of arterioles are there. And these are small aneurysms, which is called Charcot-Bouchard aneurysm. And these linings are delicate. So these small aneurysms which are found in parenchymal arterioles, there's a weakening which predisposes these small vessels to rupture readily. This is what I said, that there is, this phenomenon takes place, so there's edema, hemorrhage and rupture. And this, I told you, this occurs as a result of weakening of these arterioles, and which give rise to problem of rupture. This slide is another very important slide. This probably changed everything as far as perception is concerned, and we need to have a paradigm shift in our thinking. There were 28 cases of stroke during pregnancy, which were associated with a severe preeclamptic toxemia or eclampsia. And out of these strokes, we found that majority of them had hemorrhagic arterial stroke, and in two patients only, that was a thrombotic stroke. Now, what they found was that the multiple sites were involved, but before the systolic blood pressure was 160, 95%, 96% patients had rupture, had the stroke. And if this 160 millimeter was decreased to 155 millimeters cut off, in 100% the stroke had happened with the rise of systolic blood pressure only. The conclusion was, in contrast to severe systolic hypertension, severe diastolic hypertension does not develop before stroke in most patients with severe PET and eclampsia. It is only with the rise of systolic hypertension of 155 to 160 the stroke occurs. And that is why a paradigm shift is needed towards considering antihypertensive therapy for severely preeclamptic and eclamptic patients when systolic blood pressure reaches and exceeds 155 to 160. So this is for all the gynecologists, this is definitely a new information which is pretty old now, but whenever it comes, we should take it and start acting on it. So what did it say? Majority of time it is hemorrhagic, and in very few cases is thrombotic, and it is seen whenever the blood pressure is more than 160 systolic, and if you take a cutoff by 155, it is almost in 100%. It is like this. Only 20% were associated with diastolic blood pressure of more than 110, and 50% of these patients of severe PET and eclampsia had an associated chronic hypertension in the beginning of the pregnancy. So in contrast to the severe systolic hypertension, severe diastolic hypertension does not develop before stroke in most patients with severe preeclamptic eclampsia and eclampsia. And till now, we were always blaming, whenever the hypertension is there, it is the diastolic blood pressure which is more harmful than the systolic blood pressure. But they are revelation as far as the pregnancy is concerned. And that is why a paradigm shift is needed towards considering the antihypertensive therapy for severe PET and eclampsia when systolic blood pressure reaches 155 to 160. Foxy decided to be on a safer side. We should start acting whenever the BP is 150 systolic and 100 diastolic. To protect cerebrovascular accident and eclampsia, and from the heart, myocardial infarction and cardiac failure. So to prevent both brain and the heart, we need to act, and to prevent the baby from placental abrasion and the results and the sequelae as a result of that. So the cutoff for us is 150 by 100, and that amounts to MAP of more than 125. What are the drugs which are needed to fix it? Labetalol, initially injectable. A chart has been given again by the American College. I'm going to share it with you. And all of you know that it is contraindicated in cases of asthma, cardiac failure, in cases of bradycardia, extreme bradycardia less than 60, or diabetes. Nifedipine has to be used in the dose of 10 to 30 milligram, and then you can repeat it. Again, they have given a chart for the same. This is the American College algorithm. According to it, give this particular patient who comes to you with more than 160 by 100. Nifedipine 10 milligram is given, wait for 20 minutes, again check the blood pressure, and repeat the dose of nifedipine of 20 milligram, wait for 20 minutes, and then add on another 20 milligram of nifedipine. So it is 10, then again 20, and then again 20. And in case if it is not controlled still, and the BP is persisting by over 160 as far as the systolic is concerned, and the diastolic more than 110, they said you should change it to IV labetalol and manage this particular patients. All these patients require a very close follow-up. Very strict protocol. For first 4 hours, every 10 minutes for 1 hour, every 15 minutes for 1 hour, every 30 minutes for 1 hour, and thereafter every 4 hours. And it should be in a place where the BP monitoring and other things can be done per specific order. This is algorithm is there of labetalol. Start with 20 milligram of labetalol over 2 minutes. Repeat blood pressure. And then in case if the BP is still not settling down, then add labetalol 40 milligram over 2 minutes to be given. If the BP threshold, continue monitor the BP and the repeat BP every 10 minutes, and then you still find that giving the second dose of 40 milligram, you add on another 80 milligram IV over 2 minutes. Repeat BP, and in case it does not settle down, they switch on to hydralazone therapy. As for the intravenous things are concerned, again, the monitoring is the same as we have said earlier. It is said that the labetalol to be avoided in active asthma, in heart disease, or in congestive heart failure, and the use has to be there in caution in case of asthma and with bradycardia in a patient also. They have said that how the asthma has to be decided. Hold on IV labetalol for maternal pulse is under 60. So the details are here. You got to study time and again, and almost ratna hi padega. This is hydralazone algorithm. You start with 5 milligram over 10 minutes, then switch on to 10 milligram in case if the BP is not controlled, and then in case if it is not working out, then add on labetalol as far as switch over to labetalol intravenous switching. I again repeat that the monitoring of this particular patient for the next 8 hours or 10 hours is very, very meticulous. And that's why it has to be in a place where the person can be closely monitored. The disadvantages of hydralazine include adverse effects which mimic impending eclampsia, or syndrome which is called a HELP syndrome. So the features of hydralazine are there, that these are adverse effects are there which can mimic eclampsia or HELP syndrome, and possible increased tendency to cause serious ventricular arrhythmias compared to labetalol in women with eclampsia. So this is a little disadvantage of hydralazine, which had been in our past drug of choice. Again, it is very, very sparingly available in this country. So the drugs are nifedipine, labetalol, hydralazine, and nitroprusside is contraindicated in the later stages of pregnancy due to possible fetal cyanide poisoning if used for more than 4 hours. So all these patients, I just now said, they have to be watched for eclampsia, and that these are the usual presentation of eclampsia, how you pick it up, these patients. So the first line of drug is labetalol, second line is nifedipine, and not to use ACE inhibitors and atenolol. Whenever there is a BP of 150 by 100, we must know it, that the patient requires hospitalization. The dose of Maxell has to be given to prevent seizures in a neonate. Antihypertensives have to be given, which I've just now told you, and these patients require very close fetal monitoring. So the antihypertensive in mild to moderate, it is said that in case there is a less clear data on the maternal and fetal benefits in case we start antihypertensive agents. In 2000, there has been analysis that come that in case if you start antihypertensive agents and there is a drop of mean articular pressure of 10, there is a drop in the birth weight of 175 gram. Drop in the birth weight is seen. And this effect was unrelated to the type of antihypertensives which we had used. So people are again confused what to use in mild to moderate cases. The meta-analysis says of RCTs of treatment versus no treatment of pregnant patients mild to moderate. And 2015 CHIPS, that is Control Hypertension in Pregnancy study, that randomly assigned a pregnant woman with hypertension to diastolic blood pressure treatment. The target treatment has to be 85 to 100. Maternal treatment did not increase the risk of delivery of small for gestational age infant or cause excess fetal weight in case if you want to lower it to this level. So in fact, there were benefits that severe complications, severe maternal hypertension did not develop with this effect on the birth weight, preterm delivery, preeclampsia, and a HELP syndrome. The woman randomized to a less tighter control who developed severe hypertension had a higher rate of serious maternal morbidity. Very well shown that in case if there's a less tight control or a good control has been there, the less tight control is when the target is that, let the BP come to 100. In that case, there was no effect. The effect was the same. But if you had a tighter control, that if you aimed at a BP control of diastolic blood pressure to 85, the effects were much better. In initial, you can find the morbidity pattern was the same, but with the tight control, you could find on one side with the tight control, less tight control, it was 40%, and with the tight control, it was 27%. So are the antihypertensives safe? We all know that all antihypertensive cross placenta, there are no RCTs available, which drug to be used, and the data regarding both comparative study in improving pregnancy outcome and the patient safety are inadequate for almost all antihypertensive drugs. Uncertainty prevails, but the drugs of choice we all know, it is nifedipine and labetalol. Methyl dopa we do not have in our armamentarium. Labetalol, all of us are using and we know all about it. We know that a single dose, the effect is seen in 2 to 4 hours. The duration effect is dose dependent, and you can use from 100 to 2400. And you can see the effect of 100 milligram for 8 hours, the effect of 300 milligrams for 12 hours. The adverse effects are the consequence of blockade of beta receptors. In 10%, you can find bradycardia, and in 1 to 10%, you can find problems of dyspnea and bronchospasm. And that's why they are contraindicated in asthma. Advantages enhances fetal lung maturity and preserve placental perfusion. Nifedipine, we all know about it, but no sublingual administration need to be used. Contraindications only when there is a hypersensitivity. There are no new drugs on the horizons. The only thing what we know in a postnatal period, patient can have persistence of pre-existing hypertension. Hypertension can occur de novo in postpartum period, or they can be secondary hypertension can be there. The areas are labetalol has to be considered the first choice. ACE inhibitors and angiotensin receptor blockers need to be withdrawn if the hypertensive woman wishes to become pregnant. And in chronic hypertension, you have to be very, very meticulous in assessment before conception to exclude. So the areas of controversy still remain that diuretics not to be used during pregnancy, and Western world definitely questions calcium, antioxidants, and low-dose aspirin to readily use in pregnancy for any benefits. So the growing points are that less restricted blood pressure goal could be set for hypertensive women planning for pregnancy. A healthy body weight before pregnancy could lower the risk of pregnancy. And the recent guidelines also encourage women who with chronic hypertension to keep their dietary sodium intake low, either by substituting sodium salts before pregnancy. I have overshooted my presentation and could not be avoided. I will, this has probably confused you people much more than what you came with. Malti?
Yes, ma'am.
I'm going to stop this at
Sir ने join कर लिया ma'am.
Yes, this presentation will be available to you by evening. Malti is going to say initial 2-3 times when you read this presentation or you hear it, it is going to confuse you.
Madam, can I ask one thing?
Yes.
Is there anything called as a tightening of blood pressure? Have you heard?
Madam, tightening of blood pressure is coming back to diastolic blood pressure of 85. And
Yes.
this is what we need to learn. So I find now instead of encouraging anything, I'm going to confuse you more. We will take this particular presentation again after some time. We'll have a 10-15 minutes discussion. We have an invited guest today, Mr. Vikram. I heard him yesterday and I was impressed by his presentation. So I will invite Vikram. Not only he has a training in India, he has been trained in Japan, and finally he decided to come back and enrich as far as this particular country is concerned. So he's going to talk today how to live for 100 years. He has started a chain of physiotherapy clinic across the country, so he's going to speak something about it. So over to you, Dr. Hemant.